morning, everyone. I'll be talking about VEP, Visual Evoked Potential. So electrical signals are generated at visual cortex in response to visual stimulation. Visual stimulation is carried to occipital cortex from retina via optic nerve, optic chiasma, and optic radiation. The peripheral retinal projections are within calcarine fissure. Central retinal projections are taken to occipital lobe, and foveal projections are magnified at the cortex. The indications for VEP is optic neuritis, multiple sclerosis, optic atrophy, hereditary optic neuropathies, toxic neuropathy, traumatic brain injury, compressive optic neuropathy, glaucoma, amblyopia. Additionally, it is helpful in unexplained visual loss, malingering, pre-surgical evaluation, and measuring visual acuity in non-responsive subjects. The requirements for the test is three electrodes, active, reference, and ground electrodes. The impedance is less than 5 kilo ohms. The active and reference electrode impedance difference should be less than 20%. So the head is divided, it's an international classification where head is divided from nasion to inion based on 10-20 rule. So these electrodes are placed at, the reference electrode is placed at FZ, ground electrode is placed at CZ, and active electrode is placed at OZ. Z signifies the midline structures. This is the recording arm. So the VEP depends on different kinds of stimuli. So one is flash VEP, one is pattern VEP. The flash VEP is done by Gansfield stimulator and pattern VEP by CRT monitor. The pattern VEP is most commonly done with patients with good visual acuity. So the requirements is the patient is light adapted, seated at 1 meter with full refractive correction. The patient is undilated. The test is performed monoocularly. The other eye is patched. And the requirement is the checkerboard pattern. The pattern is reversed, that is that black to white and white to black. There are different checker sizes, 60 minutes and 15 minutes. The luminance is constant and the contrast used is high. Flash VEP is done, the indication for pattern and flash VEP is same, but the flash VEP is done in the patients with poor visual acuity. The patient is light adapted, but the room is dimly illuminated. This is also performed monoocularly, other eye is patched. The field size is more than 20 degree in flash VEP, at least one flash per second, that is 1 hertz. The flash intensity is 1.5 to 3 candela per meter square, and background intensity is 15 to 30 candela per meter square. I'll be talking about pattern onset and offset later on. So the pattern VEP is used for optic neuropathy, flash VEP for poor optics, poor cooperation, and poor vision, and pattern onset and offset is used for nystagmus, malingering, and amblyopia. So now let's come to pattern VEP. The checkboard stimuli is used. The pattern is reversed from white to black, black to white checkerboard pattern. We should also keep in mind about the artifact, that is blinking of eye. It should be lesser. The average number of tests is 64 per test. The test results is done at least twice. Every test is repeated twice. In infants and uncooperative patients, the number of tests can be reduced. So this is how the patient is seated and looks at the pattern. The checks subtend the angle of 15 minutes of arc are best for testing foveal vision. The checks of 60 minutes are superior in evaluating the parafoveal function. Therefore, using more than one check size increases the diagnostic yield. If the resulting VEP using the 16-minute check is poorly formed, the retest using an even larger check size is used. So these are the waveforms of pattern VEP, 3 waves, N1, N2, and P. So P is the positive and most important wave. The two things are important, latency and amplitude. The amplitude is calculated from the trough of the N till the peak of the P wave. It is normally more than 500 microvolts, and the latency period is on an average 100 milliseconds. This is how the report is given to the patient. Now let's come to some examples. This is a normal waveform. In traumatic optic neuropathy, there is a delayed implicit time and there is reduced amplitude in left eye, whereas right eye shows normal waveform. In AION, the normal there is implicit time is nearly normal. There is reduced amplitude and a wide waveform. In optic atrophy, there is no signal recorded in the affected eye. The other eye shows normal waveform. In neurofibromatosis, that is, there are optic gliomas. So this shows slowing of VP components in both optic nerve. In ethambutol toxicity, there is slowing of P100 peak times. Now let's talk about pattern onset and offset. In this, the pattern is on for 200 millisecond and it is off for 400 millisecond. When the pattern is off, the background illuminance is the same. This is also done with two sizes, 60 minutes and 15 minutes check. The pattern onset or pattern flash stimuli produces a more robust VP than does pattern reversal in central 30 degree. So this is the comparison between the pattern onset offset waveform and the pattern reversal waveform. So pattern reversal stimuli usually exacerbates the nystagmus, interfering with the ability of eye to maintain foveal fixation. That's why this pattern onset and offset is important for patient with nystagmus. And this pattern onset offset is less sensitive to poor fixation. That's why it is also good for testing the patients with malingering. It is also useful in monitoring amblyopia. These are the waveforms of pattern onset and offset. There are three waves. The C2 is the most important one. Normal latency is 100 to 120 milliseconds. The indications for flash VP is uncooperative patient, unconscious patient, media opacities. It prognosticates the eye with poor vision before planning of surgery and monitoring visual function of babies. These are the waveforms of flash VP. There are four waves. The P2 is the most important one. Latency is 100 to 120 and N2 P2 amplitude is more than 10 microvolts. This is how the report is given. Just a little note on sweep VP. It is used in infants, suspected malingers, and disabled subjects. The visual acuity can be calculated in logmar units. This is how the report is. And multifocal VP, it's not used that commonly. It is an objective assessment of visual field and perimetry used for glaucoma and retrochiasmal dysfunctions. These are the three waveforms, the pattern VP, flash VP, and pattern onset offset VP. Okay, thank you.
Thank you so much. Now the session of electrophysiology, which appears boring, but it is actually, once you come to know about it, it is very, very interesting, and it really, really helps to resolve the complicated, to reach the diagnosis of complicated retinal and optic nerve diseases.